Hi, I'm Joe Graydon.
And I'm Terry Graydon. This podcast of the People's Pharmacy is brought to you by Squatty Potty Toilet Stools. They create healthy toilet posture for fast, easy elimination. Learn more about toilet posture and health at squattypotty.com. That's SQUATTYPOTTY.com.
If you exercise, chances are you've experienced a sprain, strain, or joint pain. Can you heal sports injuries without surgery? This is the People's Pharmacy with Terry and Joe Graydon.
Yoga is an ancient art that can be used for healing. Dr. Lauren Fishman has written numerous books on how to use yoga for arthritis, back pain, osteoporosis, sciatica, and sports injuries. He shares his secrets with you.
Prolotherapy has been around for decades, but remains under-recognized as a healing modality. How does it work? Can regenerative injection therapy help heal injured joints without surgery?
Coming up on the People's Pharmacy, we get the latest perspectives on ancient approaches to keeping joints functional and pain-free.
First, this news.
In the People's Pharmacy Health Headlines, the World Health Organization reports that Senegal and Nigeria are containing the spread of the Ebola virus. That can't be said for Liberia, Sierra Leone, and Guinea. According to researchers for the CDC, more than 1 million people in West Africa could be infected with Ebola by the new year. That is dramatically higher than the 20,000 predicted by the World Health Organization at the end of August. The number of people coming down with this infection is doubling every 2 to 3 weeks in Liberia. The only way to stop the virus from spreading is by isolating infected patients. Only immediate and extensive disease control efforts will be able to control this epidemic.
Enterovirus D68 is spreading across the United States. At last count, more than half the states have reported cases of this severe respiratory infection. The trail of sickened children stretches from California to Massachusetts. With no effective treatment, it's likely that EVD68 will spread to all 50 states within the next week or two. Early symptoms are suggestive of a cold, but some children, especially those with a history of asthma, can develop wheezing and difficulty breathing. Any child who complains of such symptoms must be seen by a health professional immediately.
Have you ever felt embarrassed wearing one of those open-backed hospital gowns? You're not alone. Most people would probably prefer to wear their own comfortable clothing if they could, but hospitals don't usually permit this. Canadian scientists asked doctors in Montreal and Toronto to identify patients who could wear lower body garments without harm to themselves. Out of 127 patients admitted to the participating hospitals on the research day, 57 were considered eligible for lower body attire. Only 14 were actually wearing their own pants, although more than 3/4 of the patients queried said that is what they would prefer. The researchers point out that wearing home clothing could help patients ward off hospital-induced disability, presumably because it's easier to be up and about when you're not worried about exposing yourself inadvertently. The investigators suggest that patients who can do so should be encouraged to wear their own pants.
Curcumin, the active compound in curry spice, has been shown to have anti-inflammatory and anti-cancer activity. Researchers have just determined that curcumin in combination with a cancer-inhibiting protein can slow the growth of mesothelioma cancer cells and speed their demise. Mesothelioma is a cancer of the lungs that's often associated with exposure to asbestos, and it's extremely difficult to treat. The researchers hope to develop a synthetic curcumin analog that could be used for this purpose.
Does lifestyle really make a difference for preventing heart disease? That's the question Swedish scientists asked when they started a study in 1997. They recruited more than 20,000 healthy Swedish men between 45 and 79 years old and followed them until 2009. Those who adhered to 5 healthy habits lowered their risk of a heart attack dramatically by over 80%. They exercised regularly, ate plenty of vegetables, fruits, and whole grains, drank moderately, didn't smoke, and kept their waistlines at or under 37 inches. Even following 2 or 3 of the healthy behaviors lowered men's risk of a heart attack compared to the men who didn't practice any of them. If you ever get frustrated about conflicting health information, keep in mind that these simple guidelines have not changed in decades.
The Institute for Safe Medication Practices monitors the reports of adverse drug events that FDA receives each quarter. In its most recent report, patient safety analysts noted that the stop smoking drug Chantix has a higher likelihood of triggering suicidal or homicidal thoughts than any other medication. Comparing Chantix to drugs like Singulair, Paxil, or Seroquel revealed that Chantix outnumbered the others nearly 3-to-1 when it came to suicidal or self-injurious thoughts. There was a 5-fold difference between Chantix and other drugs with respect to homicidal plans. The authors of the report call for stronger, clearer warnings about the potential risks of this stop-smoking drug, especially its tendency to trigger aggression and violence. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. One of the most important things we can do for good health is move our bodies. Exercise is essential for our hearts, brains, and emotional well-being.
But vigorous exercise can lead to injuries. How can you heal a sprained ankle, a torn rotator cuff, or a sore joint? Are there strategies that can help overcome sports injuries without surgery?
To answer these questions, we turn to Dr. Lauren Fishman, Medical Director of Manhattan Physical Medicine and Rehabilitation in New York City. He's written 7 books, including Yoga for Arthritis and Yoga for Osteoporosis. Dr. Fishman is also Associate Editor of Topics in Geriatric Rehabilitation and a former president of the New York Society of Physical Medicine and Rehabilitation. He's on the staff at the Columbia College of Physicians and Surgeons. His website is sciatica.org.
Welcome to the People's Pharmacy, Dr. Fishman.
Oh, it's a pleasure to be here.
Well, it's wonderful to have you back. Dr. Fishman, our listeners may not know what you do. You are a physician physiatrist. So what is this specialty called physiatry?
Well, it's a medical specialty. You know, we go to medical school and then there's a 4-year residency in this. And what it amounts to really is the way an obstetrician presides over a birth and may not have to do anything. Nature may take its course without any intervention, whatever. In the same way, we preside over recovery from illness or from injury or from genetic or birth disabilities. They may occur later in life, too. So what we're there to do is to help people function better so that if someone has, let us say, a loss of an organ or the loss even of a limb, we're not concerned with the loss of the limb as much as we're concerned with what that person can do. The loss of the limb may come from a surgical thing or, as we say, from birth. But the actual ability of the person to do the best they can is what we try to promote.
Now, as I understand it, physiatry is also sometimes referred to as physical medicine. Is that correct?
That's correct. What does that mean?
Yes.
You know, originally, physical medicine included radiology. Today, with all the ultrasounds and MRIs and so on, we conceptualize it as a completely distinct field. But you can distinguish between medicine and physical medicine because the medicines use medicine. They use cortisone, they use antibiotics, they use thyroid hormones. These are all medicines. We use physical means, which includes radiology. It really does, even though it's split off. It includes electricity, it includes ultrasound, and of course exercise, simple Newtonian mechanics. Recently, it's begun to include a whole lot of new things, such as lasers, and there are many other technical pieces of apparatus and equipment that we use in rehabilitation. For example, the same person who lost his or her arm can have a device, a high-tech device that replaces the arm and allows the person to eat an ice cream cone or write and do a whole lot of things.
Now, when I think of sports injuries, for example, or perhaps an older person who's beginning to experience osteoarthritis of the knees or the hips. I think generally orthopedists, the orthopedic surgeons are often called in, but that field is mostly bone. They deal with soft tissue injuries, but oftentimes what they like to do is put in a knee replacement or put in a hip replacement. So is the difference between what a physiatrist does and what an orthopedic surgeon does bone versus soft tissue? Help us understand where
No,
that
I don't think. Yeah, I don't think that's really. I mean, we have a very uneasy a good relationship, but a constantly changing one with the orthopedic surgeons, because I consider part of my job to keep people out of surgery if I possibly can. At the same time, if they need surgery, it's another part of my job to tell them they need it and to send them. And then my job after that is to rehabilitate them after the surgery has been done. Because however you look at it, surgery is anesthetized, antiseptic violence. And people have a good deal of trouble recovering from it. And rehabilitation is perfectly suited to bring people back to the level they were at before they had it or above that. So it's not soft tissue versus hard tissue. It's really, we're more like medical orthopedists. We don't do the surgery. We often find that exercise and movements of different kinds are not only as good as surgery, they're actually better. I can give some examples of that. We have a cure for rotator cuff, which astounds and befuddles many surgeons, though a few have understood it, where we recruit another muscle to do what the injured muscle no longer can do. And these people are 100% better within about, honest to goodness, 5 minutes at the most.
Well, wait a second.
Then the other,
back up just a second and explain to us, what is a rotator cuff injury? And what are you doing to make it better?
Yes, it's very interesting. It's actually it's something I got out of yoga. A rotator cuff injury is when the supraspinatus, or one of the other muscles of the four that make up the rotator cuff, gets torn. The tear can be partial or complete. And the first case I had was a total and complete tear, the two parts of the supraspinatus, which is injured at least 90% of the time, and is the muscle that raises the arm about horizontal, just below horizontal to just above horizontal, that 20 or 30 degrees there, that are otherwise, it's very difficult for the deltoid to do that, because the deltoid is just pulling horizontally and cannot, like a clothesline tied to a tree, you can pull on it and make it horizontal, but no matter how hard you pull, you're never going to get it to rise above that level. The same way the deltoid can raise your arm to horizontal, but right there it gets stuck because its fibers have no vertical component to them. So that's where this little muscle that gets torn in the rotator cuff comes in, the supraspinatus. And that muscle usually lifts the arm another 10, 20, 30 degrees. And then there is a vertical component to the deltoid, and it can do the rest of the job and raise your arm all the way up to vertical. But when it's torn, the deltoid pulls very hard and pulls the head of the humerus, the arm bone, right into the socket of the, it's called the glenoid fossa, where it attaches in the shoulder, and it hurts like the dickens. So what we found is a simple yoga pose, which we got from headstand, though we don't have to do headstand anymore. It's a really simple thing. We can recruit another muscle, the subscapularis, which is also in the rotator cuff, but is much less frequently injured. And we get that muscle, it's going to sound strange, to work like a teeter-totter, like a cantilever bridge. The deltoid raises the arm to vertical, and then the subscapularis pulls down on the head of the humerus, that round ball at the top of it. The deltoid holds steady. The bone is held steady by the deltoid, which acts like a fulcrum. The supraspinatus isn't working at all, but the subscapularis pulls down on the head of the humerus. And on the other end of the fulcrum, the whole shaft of the humerus rises. And it only has to rise 20, 30 degrees, and then the deltoid can take over as it would in the normal case. So it's a very simple process of getting the subscapularis activated and then having the person quite immediately raise their arm. Now, there's so much pain involved in raising your arm the old-fashioned way with the torn supraspinatus that it's sort of a form of operant conditioning, and the person immediately learns. It just doesn't take a second for them to learn how to use the new way, and they just raise their arm from that point on using the subscapularis. I have patients, honest to goodness, 10, 12 years ago, who are still lifting their arms perfectly. And I have MRIs to show that the supraspinatus usually, unfortunately, doesn't heal. This other mechanism is perfectly solid. There is a little bit of a disadvantage. They get a little bit more osteoarthritis in that shoulder, but then many people do have the surgery too. Surgery takes 3 months of rehab to recover well, and it's quite painful. I know because I had it on the other shoulder. This one, there's no rehabilitation except learning this pose. People walk out of the office just as though they never had a rotator cuff.
Dr. Fishman, what other sorts of conditions can physiatrists help people with?
Oh, my God, the list is really long. There are, of course, recovery from automobile accidents and in wartime. We do things that range from teaching people to use artificial limbs to recovering from post-traumatic stress syndrome. When it comes to ye old normal person walking around in New York or Kansas City, we take care of osteoarthritis of the hip and the knee and the shoulder and the spine, where they most frequently occur. We take care of people after cardiac illness and cardiac surgery. We also do a great deal for children who have, for one reason or another, disabilities. Old people are almost a specialty of ours. Like geriatricians, we are more gentle than their other practitioners and take care of them. We kind of understand, I'm going to make up a term here, I call it the ecology of illness. What happens is that the body is well connected to itself, and there are chains that are where the links are not easily broken. For example, if something goes wrong in the hip, well, the knee and the ankle also support you every time the hip does. And so if something is wrong in the hip, then the knee, which only has really one motion back and forth, is constrained to do things that it wasn't designed to do. So you get problems in the knee. The same is true for the ankle and the sacroiliac joint and the spine. Once one of those joints goes, the others along the chain are likely to be involved too. And that's something I think we as physiatrists understand in a way that few other medical specialties do. They're very involved with doing what they're often have to take a kind of blinder approach where they're looking at the knee and they're not seeing the sacroiliac joint or the thoracic spine.
You're listening to Dr. Loren Fishman. He's medical director at Manhattan Physical Medicine and Rehabilitation. He's also author of 7 books, including Yoga for Osteoporosis and Yoga for Arthritis. Dr. Fishman is on the staff at the Columbia College of Physicians and Surgeons. His website is sciatica.org.
You know, Terry, physical medicine may not be as sexy as surgery, but it can often be quite effective.
That's right, and it really isn't as well known as it deserves to be.
We need to take a short break. When we come back, we're going to learn about yoga as a healing modality.
One of the best-kept secrets in sports medicine is prolotherapy. What is it, and how does it work?
We'll find out what exercises are best for aches and pains, and we'll learn about regenerative injection therapy.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like this podcast of The People's Pharmacy and want to continue the conversation, you can join us online at facebook.com/People's Pharmacy to share your thoughts or comments. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by Squatty Potty toilet step stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
And by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. The number's 800-345-7339. Online at uttercream.com.
If you'd like to order a CD of this show, you can call 800-732-2729. 800-732-2334. This is show number 963. That number again, 800-732-2334. Or place the order online at peoplespharmacy.com.
Today on the People's Pharmacy, we're talking about sports medicine and how to keep joints working well. How can injuries be treated effectively without surgery and with the least time away from exercise?
Our guest is Dr. Lauren Fishman, Medical Director of Manhattan Physical Medicine and Rehabilitation, and author of Yoga for Arthritis and 6 other books.
Dr. Fishman, you're renowned for using yoga as part of the healing process. Can you tell us how you would do that for someone who, for example, might have some osteoarthritis of the hip or the knee, or perhaps their ankle is giving them trouble because of a bad sprain? How do you begin to integrate yoga into the recovery process?
What I try to do is recognize how yoga works in their particular case. Let's say they have osteoarthritis, and so their motion is reduced beyond what it could be. First thing I do is secondary prevention. The hip is in trouble. You don't want to move it as much as you did before, and pretty soon it's much tighter than it has to be. So the first step is use very simple forward bending postures, or postures where you lie on your back and you raise your leg up towards over your head. And you just increase the range of motion ever so slightly, not just on that leg, but on the other leg too. Thereby, you allow the person a wider stride. You give them a chance to do a lot of things they couldn't do before without any pain at all, which kind of emboldens them and gives them an idea of the kind of thing they can do. Then you, having increased the range of motion, you then work to doing things like standing poses, which can increase their strength and make them more stable, give them a better sense of balance. It also works to improve their coordination, which is frequently involved in hip arthritis. People are depending on their hip to do things that the hip really can't comfortably do for very long. So that's the beginning of how we would work with yoga. The nice thing about yoga is that it's memorable. So once the people learn how to do it, they can do it on their own. They're not hooked on coming to physical therapy all the rest of their lives, and they get a sense of independence and of accomplishment and of self-reliance that is very important for their living with whatever it is they have.
Dr. Fishman, have you ever heard of something called prolotherapy? Apparently it's been around for several decades, and nowadays there are some modern changes that involves stem cell injections. Does it work, and how does it work?
Well, those are two very different things. The prolotherapy is generally aimed at causing a fusion, a junction of the two parts of a joint. The place where I think it's most successful is the sacroiliac joint, where they will inject a 10% sugar solution or calcium chloride or vitamin B12 even. They will inject something that will actually agglutinate and stay in there and give the joint less motion because it's the motion that is usually so painful. Normal motion is painless, but abnormal motion causes a lot of the pain. That's prolotherapy. Now, when you talk about the stem cells and about PRP, which is platelet-rich plasma, then it's a different story. Those are very interesting. In fact, I'm using them too. Uninvasive as I am, I've saved a number of people from knee surgery using them. And I'll tell you something that happened to me a couple of weeks ago after I explain what it is. It's you take a person's blood, maybe 60 cc's, which is less than a transfusion, more than when you donate, less than when you donate blood, but still something. And you spin it down in a centrifuge, and you get out of the 60 cc's 2 cc's of reasonably pure platelets. Then you inject the platelets, the person's own platelets, back into them in the spot that is in trouble. And the idea is that the platelets don't live very long. They live a couple of weeks. But in the course of that, they give off cell signaling molecules. They give off signals that tell the cells that are there, that are resident in the knee, to start acting the way they acted before the person was mature. They sort of de-differentiate. So a cell, for example, that is now there to sustain cartilage gets a fountain of youth and gets younger and acts now like a cell that doesn't sustain cartilage but makes cartilage. So if you have a loss of cartilage, all of a sudden it'll grow it again. Now, it doesn't always work, but I had a case a couple of weeks ago of a man who had knee problems, and we got an MRI, and he had a torn anterior cruciate ligament. And I gave him the platelets, with platelet-rich plasma. And then 3 weeks later, he fell. and I had to get another MRI. So I got another MRI, and the MRI person who read it at the radiology laboratory didn't know anything about this platelet-rich plasma or anything else. And he wrote with a rather surprised tone, as best you can divine out of the written word, he said, there is, compared with the last MRI 4 weeks ago, there is an improvement in the anterior cruciate ligament. We see fibrocytes. We see new cells growing there. So that's the most striking immediate confirmation of the value of the platelet-rich plasma that I've seen. I've seen some pictures from Korea where I believe they're quite a bit ahead of us. And I see the same thing happening. They have an MRI of somebody's medial meniscus year 1 and then year 2. And there's significant growth and increased thickness of the collateral ligament and of the medial meniscus.
Dr. Fishman, as people get older and as they have some aches and pains and some issues that restrict their movement, what kinds of exercises, what kinds of movements would be the most appropriate for good health? So I'm just wondering, elliptical machines, is that the way to go? Gentle walks rather than running? And what about things like Tai Chi and yoga?
Oh, Tai Chi is wonderful. I believe the best things for people are the ones that they can do without a class, the ones they can do on their own. When they're in the hospital, when they're on a long trip, things of that sort. And Tai Chi is really in there, and I feel ashamed that I haven't mentioned it sooner. It's a wonderful one. And Pilates is good some of the time. I'm not as enthusiastic about it because I'm not sure it's responsive to the different problems people have, and it's vigorous enough to be possibly dangerous. Tai Chi is not, as I can see it, dangerous at all. It improves your range of motion and your sense of balance, your ability to handle your own center of gravity very well. I would say if it's sort of like saying, well, what do you do for cancer? And that depends on the particular kind of cancer it is and the particular stage of pathology you're at. And when you say, what should you do, it's a very general question. And the best general answer I think I can give is staying active in a way that is beneficial rather than risky. Tennis is a lot of fun. Being in a group is wonderful for your social relationships. Another critical thing you need as you get older. But when it comes to your body, when it comes to your being able to move and so on, I think you're better off with something. My favorite, paid political announcement is yoga.
Well, we all want to enjoy our game, whatever our game happens to be. So I'm hoping, Dr. Fishman, that you can tell us how listeners would be able to find a physiatrist in their own area if they had a problem that they thought perhaps physiatry might be able to help.
Mm-hmm. Well, 2 little syllables, Google. We're all over the place. We've spread across the country like a virus. They're physiatrists just about every medium-sized city. If you can't find one, the university and the medical school in your state almost undoubtedly has an excellent department of people who've decided to devote their lives in part to patients and in part to teaching students. That's the best way to do it. And physiatrists, as I say, there's this uneasy relationship. They try to keep you out of surgery. But when you need surgery, the conscientious one will send you. And will send you, and you will have confidence that that's what you really need. And if you need the surgery, they'll take care of you afterwards. But most of the time, you will never need the number of a surgeon. You'll be able to accomplish whatever you hope to get out of the operating room without ever entering it.
Well, before people can search on Google for physiatry, they have to know how to spell it. So could you help us?
That's true. Physiatry. It's also called physical medicine and rehabilitation. Now, our department up at Columbia, the head, Joel Stein, who comes to us from Harvard and who's really good, he has changed the name of the department to rehabilitative and regenerative medicine because the stem cells and the platelets and so on are forming an ever-increasing part of the way you can avoid surgery.
Dr. Loren Fishman, thank you so much for talking with us on the People's Pharmacy today.
Oh, what a pleasure. Wonderful to talk to you, Bob.
You've been listening to Dr. Loren Fishman, Medical Director of Manhattan Physical Medicine and Rehabilitation.
We turn now to Dr. Brian Scheipel, Director of the Center for Sports Medicine in Springfield, Pennsylvania. His book is Regenerative Healing for Life, a new paradigm to treat injuries and pain without surgery.
Welcome to the People's Pharmacy, Dr. Brian Scheipel.
Thank you for having me, Joe and Terry. It's a pleasure to be here.
Well, it's nice to have you on board. And Dr. Scheipel, let's just start at the very beginning, because you have written a very interesting book called Regenerative Healing for Life. And in this book, you talk a lot about this thing called RIT, Regenerative Injection Treatment. What is it? How long has it been around? And why is it one of the best-kept secrets in medicine today?
RIT is a acronym for most commonly thought of as prolotherapy. But there are other treatments now that are included in RIT as things have progressed and science has progressed. Prolotherapy has been around, if you can go back to the dawn of time, or at least the dawn of medicine, when some of our earliest doctors used a hot poker to insert into a javelin thrower's loose shoulder and started a healing process with heat in a loose shoulder capsule, and the javelin thrower is able to get back to doing what he needs to do.
You're talking about what time frame?
Thousands of years ago?
Oh, yeah, about 2,000 years ago.
Okay.
Okay, so over the centuries, doctors have known that patients had these kind of laxity and loosening and instability problems, and they've been very creative, from injections to surgical procedures, to try to get our joints tighter, stronger, more stable, which equates to increased function and decreased pain or elimination of pain. So that's kind of the principle. And early on in the 1930s, doctors started using certain chemicals injected around the time that hypodermic needles were being used to infiltrate our patients that needed IV solutions to keep them alive and keep them hydrated during surgery. They would inject dextrose into the vein, and if the steel needle slipped out of the vein, this dextrose would cause a scar or a lump of hard tissue outside of the vein, and the surgeons kind of put two and two together and said, well, maybe this stuff will help people heal.
So dextrose is?
Dextrose is sugar water. And so when we're doing trying to keep a patient alive who can't eat in the hospital, it's very common for them to have an IV solution, mixture of sugar, dextrose, and water to keep them hydrated and give them a little bit of sugar to keep their blood sugar up. And that was used way back when, and that's how the initial doctors like Dr. Hackett and Hemwell started thinking about using this term. Prolotherapy was actually created by Dr. Hackett, and he was a general surgeon. And he started injecting his patients and friends and families different joints and ligaments, and lo and behold, it helped them like he thought it would.
Do we have any idea why it works? Or how?
Well, it was a theory, and now that theory has been studied at the bench research level in the lab and in animal studies and whatnot, and it's been confirmed to a great degree that our initial theories were correct. And the theory is that dextrose causes a osmotic shock or inflammation of our tissues when injected, and that inflammation causes the body's healing cells to be brought into the area, releasing certain growth factors that start a healing process. And that healing process can now be injected again and again over several treatments until the tissue is fully healed. Where what happens to begin with, when we're injured, we have a chance to heal, but not all the time. Not all the time that do we heal properly, and we don't heal completely, and we'll end up with an unstable ligament or a tendon that hasn't fully healed and will break down again.
Dr. Scheipel, why is it that prolotherapy, which as you've just described, has been around since the 1930s, so basically over 80 years, is not better known by physicians or patients? There certainly are a number of practitioners out there, oftentimes doctors of osteopathy, who are quite familiar with it, but your average orthopedic surgeon seems somewhat oblivious.
And the average even primary care physician, I would say the same thing. That goes back to, at one time, like back in the 70s and 60s, even our Surgeon General, who was a surgeon, he was a pediatric surgeon here in Philadelphia, C. Everett Koop, was helped by the treatment. And he didn't use it on his pediatric patient population, but he used it on their parents and his friends and family, and was a big advocate of it to the point where he was in a letter-writing campaign with the Medicare people in Washington to try to get it approved. And so it actually had pretty good popularity back in those days, but the doctors that were being trained had the idea that stronger was better, and they started using pretty dangerous chemicals in their treatments, and they started hurting patients. And this was probably right around the time that lawyers started figuring out they could sue a doctor for injuries and harm. And these initial damage cases where patients were harmed by these stronger solutions really almost killed prolotherapy for good. And then in the 80s, this new specialty of physiatry was born, and a physiatrist's job is to handle chronic pain. And they're constantly looking for new ways and new tools to treat their patients, to try to help them with their chronic pain. And they started resurrecting. They found these old articles on prolotherapy, and they started studying it at the research level. And lo and behold, these studies started to show some promise. And that kind of resurrected prolotherapy back in the 80s. And some of our professional associations were born around that time. And the teaching and the word started to spread more aggressively from the 80s till now. And now it's much more popular. The research coming out of our medical schools and research centers and private doctors' offices is much more robust than it has been in any other time. And it's a pretty exciting time for prolotherapy, and I think we're very close to being able to say without a shadow of a doubt that our theories have been proven both at the bench level or the lab level, and also in the clinical practice of prolotherapy.
You're listening to Dr. Brian Scheipel, director of the Center for Sports Medicine in Springfield, Pennsylvania. His book is Regenerative Healing for Life.
Coming up, we'll find out what kinds of injuries respond best to prolotherapy.
We'll also learn about platelet-rich plasma and whether it works for arthritis.
A lot of people have knee pain. Where does physical therapy fit in?
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Squatty Potty Toilet Step Stools, creating healthy toilet posture for fast, easy elimination. More information about how toilet posture affects your health at squattypotty.com.
And by Red X Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel soft and smooth. 800-345-7339, online at uttercream.com.
If you'd like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 963. That number again, 800-732-2334, or find it online at peoplespharmacy.com.
We're talking about sports medicine and how to keep our joints working well. Our guest is Dr. Brian Scheipel, director of the Center for Sports Medicine in Springfield, Pennsylvania. He's assistant clinical professor of family and community medicine at Temple University School of Medicine. His book is Regenerative Healing for Life, a new paradigm to treat injuries and pain without surgery.
What sorts of problems or injuries respond best to prolotherapy or other sorts of regenerative injection therapy?
Well, anything that in the musculoskeletal system that causes pain and dysfunction. So, for instance, a joint is held together by ligaments. When those ligaments are sprained, that joint can be loosened up and it can be permanently loose. And if we inject those ligaments, we can make them stronger and return the stability of the joint. And that can help the patient's pain and function greatly. Just to give you a quick little story that's actually in the book that turned my attention to prolotherapy in a serious way, that I thought I needed to learn this and start offering it to my patients as a sports medicine doctor. There was a colleague of mine in the Midwest, and one of his football players at the college he was the team doctor for sprained his ankle. And this young man had a really good first year in the NCAA, and his second year he only rushed for a few hundred yards because his ankle was so badly sprained and it wouldn't heal. So they did a few prolotherapy treatments in the summer, and he returned back to his team his junior year, and he had 2,000 yards rushing his junior and senior year and won the Heisman Trophy. And that made me sit up and say, I have patients like this that we can't get better with just physical therapy and a brace, and they're not able to get back to full capacity, and this is something we need to seriously look at, and that's how I got started. And so that's in a situation where a ligament is unstable. Now, if a tendon is damaged, like a tendinitis or a tendon tear, a lot of what we call a tendinitis is really a torn tendon when we look at it closely with diagnostic ultrasound. And if we inject dextrose or platelets, platelet-rich plasma is a stronger form of regenerative injection therapy than even dextrose is. And platelet-rich plasma is where we take our patient's blood and spin it down, and we separate the platelets and the plasma from the red and white blood cells and use that as our prolotherapy solution. And it stimulates an even stronger growth factor response in the tissue, and we get even stronger healing. So both of them are used interchangeably in situations where the tendon is damaged or the ligament is damaged. And then we can also treat cartilage conditions in our damaged joints or even arthritis. And that's almost a bridge too far. Our surgeons ask, how the heck can dextrose or platelets help arthritis? And we believe it's really on the growth factor level. And when you look at the arthritic joint has really high levels of abnormal proteins in there, growth factors, that destroy the joint. And when we inject dextrose or even PRP, we're putting in a flood of good growth factors that outweigh or tip over this imbalance in the joint and bring the joint back to a healthier state. And that can equate to pain relief, increased range of motion, decrease in their swelling. It can also lead to improvement in the cartilage condition from healing cartilage or healing meniscal tears or cartilage tears in the shoulder, hip, and knee, or growing back surface cartilage that has been knocked off or worn off in arthritic situations. So there's all these different uses. We can also treat muscle tears or the fascia. The fascia is a very thin covering of our muscles that is essential for proper muscle function and can cause severe pain when it's torn. And we can see this with ultrasound and guide our needles into there and repair the fascia as well.
Dr. Scheibel, knee problems are all too common. I wonder if you could tell us about a patient you treated, Eric.
He had arthritis in his knee, and he saw his orthopedic surgeon, and they wanted to do a joint replacement, actually, on him. His arthritis was so advanced, and he was looking for an alternative treatment. And after the surgeon gave him a cortisone shot, sent him to therapy and whatnot, he still was not doing well months later. So he came to me, and we talked about he had been through a proper course of conservative therapy, he had a cortisone shot, he did therapy, he wore a brace, he was still having difficulty at work after the effect of the treatment wore off months later, and he was looking for something more permanent. So I went right to prolotherapy with him and explained to him that in an arthritic joint, the prolotherapy works very well. We actually have a very good, recently published NIH-funded study showing that it does work well for arthritis of the knee. And we started with one prolotherapy injection into his joint, and that calmed his pain down, and he remained calmed down. We did a few more treatments over the course of a year, just injecting the dextrose directly in the knee, and it maintained his good pain relief. And at the end of 1 year, he was doing great. He had absolutely no problems in that knee at all.
Now, you mentioned a study, and a lot of our listeners, especially the physicians who are sort of shaking their head in amazement, like, what are they talking about? I never learned about prolotherapy in medical school. There was an article in the Annals of Family Medicine that was published in the May-June issue of 2013. This was a randomized controlled trial, and their conclusions were that prolotherapy resulted in clinically meaningful, sustained improvement of pain, function, and stiffness scores for knee osteoarthritis compared with blinded saline injections and at-home exercises. Is that the study you're referring to?
That is the study. That's our big landmark study that is really at the top of all the studies right now.
While we're talking about knees, I was very impressed with your account of a woman who was training for her black belt in karate. And as a karateka myself, that caught my attention. She had a knee injury and really harmed her ACL. Tell us why you did prolotherapy on her and how it worked.
I remember her case like it was yesterday, and we've treated many dozens of cases since then. She planted her foot wrong and twisted her knee and felt something pop. And when she tried to get back up on her feet after she fell to the mat, she had difficulty balancing on that plant leg and kicking with her other leg. And so she was trying to get ready to test for her black belt, and every time she did, she would collapse to the mat, and she said, "There's something wrong with my knee, I have to go get surgery." So she saw two orthopedic surgeons who looked at her MRI and gave her an exam, and they both said, "Well, you have a partial tear. I don't do surgery on partial tears. This may heal some more, or maybe it'll tear the rest away, and then I'll do it." And that was not the answer she was looking for. She wanted to be fixed. So she looked around and asked her friends and family and doctors, any other suggestions, and my name came up. And she's in my office. I examined her and said, "Your ligament is not doing its job. You have a very loose knee. The MRI shows that your ligament is hanging on by a thread, but it's almost completely torn." And I said, "If we use dextrose, prolotherapy injection, you have enough of the ligament attached that we should be able to rebuild this ligament and give you your stability back." And I said, "It's a theory. We don't have hardcore studies proving this, but I have heard of this in my at meetings and whatnot of patients being treated this way. Let's give it a try." So I used the technique that we use to train physicians on how to inject the ACL. We injected her ACL and her joint. It was 3 injections, and we did it. We did the treatment 3 or 4 times, and about a month apart. And then I saw her a month later for her next injection, and examined her and said, "Your knee is tight as a drum. It's completely stable now. How are you doing clinically?" She said she's doing great. She's able to jump, plant, spin around on it, doing flying roundhouse kicks and everything. And her knee she felt like she had a brand new knee. And she went and got her black belt, and I still take care of her family today, 10 years later.
Dr. Scheipel, is it possible to use a regenerative injection therapy for nerve problems?
Yes, and what we learned early on was if we took a full-dose prolotherapy solution and injected it near a nerve, like say a patient has carpal tunnel syndrome, and their hand is painful and falls asleep at night and have trouble holding their work instruments in the day, and if we put full-dose dextrose around that nerve, it really irritates the nerve. So a doctor smarter than I started dropping the dose of the dextrose down, and the literature shows that low-dose dextrose, only 5% dextrose, is actually very therapeutic to a swollen nerve. It actually causes the nerve to stop pumping out abnormal nerve proteins that keeps the nerve inflamed and painful. And it's not a steroid. We use 5% dextrose, and it calms the swelling of the nerve probably as effectively as steroid, and it keeps it calmed down for many days. And when you do that, the nerve starts to recover, especially if you do it more than once. So we also use, with ultrasound guidance, we mix the dextrose with water and a little bit of Novocaine, and we surround the nerve in an entrapped tight spot, and we can open that spot up using hydrostatic pressure under ultrasound guidance, and it frees the nerve up. And we call this hydrodissection of a nerve, and it can, if you free the nerve up in that impingement point or entrapment point, the nerve can recover so effectively that it essentially cures the condition. And we're doing this literally all over the anatomy where we can get a needle on an entrapped nerve. And so it's not, I don't call it prolotherapy of the nerve. We call it hydrodissection of the nerve with low-dose dextrose. And it works very, very well in all but the most severe cases.
Dr. Scheipel, would it be correct for me to interpret that the first thing that a person needs to do after injuring a joint or muscle is physical therapy?
Well, I'm going to say, assuming that the diagnosis is accurate, which is a common problem. A lot of patients, there's so much information available on the internet now that patients tend to treat themselves, which is fine. They make the wrong diagnosis and they go down a treatment pathway that doesn't help them. And meanwhile, their tissues are getting atrophied or more torn or more inflamed, and when they get to me, they're pretty severe. So let's assume that the patient has the right diagnosis. Sometimes relative rest, where if they're a runner, they switch from running to, say, riding a stationary bike or getting in a pool and allowing their tissue to heal. And if that's not going well in a brief period of time, let's say a week, then they should get under the watchful eye and professional hands of a physical therapist who can help improve the flexibility, strength, while their body naturally heals, and that can go a long way. So my therapists in my community are very, very important to my practice, and a well-timed physical therapy consult can really help a patient, and it can help them avoid needing prolotherapy many times.
When might a person seek prolotherapy, and where would they be able to find a qualified practitioner?
That is the $64,000 question. There are conditions, if a patient hasn't healed in what I will call the old paradigm course of treatment, which can be time, just giving the injury time to heal, doing good physical therapy, and good is the emphasis is on good, because there's not a lot of our therapists are very good at helping our patients heal. So I have my hand-picked therapy houses around me that I trust, and then, if they see a surgeon and a surgeon does a well-placed cortisone injection in a joint or a bursa, I don't have a problem with one shot to try to help the patient get through their problem. It can be detrimental, but many times it's kind of no harm, no foul. But if one shot and one round of therapy and the tincture of time has gone by and the patient's not turning the corner, that would be a time to think about getting prolotherapy or get evaluated by someone who knows how to perform prolotherapy in an expert fashion. And then how to find a good prolotherapist, I would advise patients, many of our societies or professional societies have websites, and the websites have a listing of physicians that have trained under these societies to learn how to do prolotherapy. It doesn't mean they're an expert, but at least it's a starting point. And what a lot of my patients tell me is they go by word of mouth, they go by blogs. So, for instance, there's a hip injury website called Hip Chicks, and these women have undergone arthroscopic hip surgery for labral tears and other problems, and they didn't get better. And they kind of formed this blog, and they talk to each other about where to go from here, what doctors are providing treatments that can help them get better after their surgery failed. And that's where some of my patients said they saw my name mentioned that I'm an expert at doing this type of treatment. And I get patients literally from all over the country because of this blog. So there's many sites that list physicians that have trained in prolotherapy, but to find the one that's the most competent in your community You need to talk to your doctors that refer patients to these people, or the therapists that know their work, and or chiropractors even that know their work. There's usually in every community, the guys that do good work with prolotherapy and PRP are well known in those communities.
Dr. Brian Scheipel, thank you so much for talking with us on the People's Pharmacy today.
Thank you very much, Terry and Joe. It was a pleasure.
You've been listening to Dr. Brian Scheipel, Director of the Center for Sports Medicine in Springfield, Pennsylvania. He's Assistant Clinical Professor of Family and Community Medicine at Temple University School of Medicine. His book is Regenerative Healing for Life, a new paradigm to treat injuries and pain without surgery. You'll find a link from our website.
We spoke earlier with Dr. Lauren Fishman, Medical Director of Manhattan Physical Medicine and Rehabilitation in New York City. He's written 7 books, including Yoga for Arthritis and Yoga for Osteoporosis. Dr. Fishman is Associate Editor of the journal, Topics in Geriatric Rehabilitation. He's a former president of the New York Society of Physical Medicine and Rehabilitation, and he's on the staff at the Columbia College of Physicians and Surgeons. His website is sciatica.org. You will find a link to it from our website.
Lynn Siegel produced today's show. Al Wodarski engineers the program. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Red-X Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. The number is 800-345-7339. The website is uttercream.com.
To order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 963. That toll-free number again, 800-732-2334, online at peoplespharmacy.com.
And when you visit the site, you can check out prescription drugs, herbal medicines, and home remedies. Check out our new design as well. Tell us what you think about it, or share your own experience and your thoughts on today's show.
Sign up for our free online newsletter or the free podcast of the show. You'll never miss another People's Pharmacy program again. You can also share it with a friend. It's all there at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to the People's Pharmacy.